Distinguished professors, dear colleagues, today we are gathered here to talk about a disease and a treatment which requires collaboration and cooperation, both nationally and internationally. And I'd like to welcome all of you to this meeting, and I hope that this will be a fruitful meeting. The first speaker today is a mother and a doctor. She's Dr. Robin Ely. She graduated from Georgetown University and completed her family medicine residency. Her child, Brian, was diagnosed with Gaucher disease in 1983, and she started looking at solutions. She met Dr. Brady at NIH, and she started working there voluntarily in his laboratory. Thanks to that, her son Brian was the first patient who received enzyme replacement therapy. It wasn't just for the Gaucher disease, but an inspiration for the treatment of many other diseases. Dr. Ely is a founding member of the National Gaucher Foundation. She's been a medical director and president and a consultant for many years. Shall we listen to our hearts or our brains when we're taking treatment decisions? This is a question that always confuses us. But if it is your child who is in question, it becomes even more prominent. In this case, you don't only use your mind, but also your heart, and you start seeking, you'd start searching, not just for your child, but also for the other children and adults around the world. And you inspire people not just for Gaucher disease, but for other diseases as well. So we're going to listen to the story of a heroine, both a mother and a doctor. Dr. Illy, it will be our great pleasure to listen to you.
Thank you so much, all of you, for coming and listening to this story. And I actually am really hopeful that at some point I can come to Turkey and visit with physicians who are treating Gaucher patients. I'll tell you, I was asked to talk about what it was to be a mother of a child with a disease that for which there was no treatment. And I can tell you that for me, I, as a physician, noticed that that Brian's spleen was getting larger. And I took him to a hospital called Children's Hospital in Washington, D.C. And they did a bone marrow, which at that time was necessary. They didn't have the DNA and so forth at that time. And bearing in mind, this was 43 years ago. He's now 46. So the hematologist said to me, "Your son has Gaucher's disease." And I remembered that a man named Dr. Brady had come to my medical school, which is in Washington, and talked for about 10, 15 minutes about this abstruse disorder, which most of us promptly put out of our minds. And so she tells me he has Gaucher's disease, and I'm so sorry, there's no treatment. You need to be prepared because he will die very soon. I cannot begin to tell you how horrible, how utterly horrible that experience was. And at that time, I had 3 children, a 4-year-old, a 3-year-old, and a 1-year-old. And so my husband and I were absolutely distraught. And then my mother, who was a great lioness and a very brilliant woman in her own right, had gone to Israel the summer before, because this was like in about September when we found this out. And she had met the head of the Weizmann Institute. And she called him up and said, "My grandson was diagnosed with a disease called Gaucher's. Have you ever heard of it? Do you know anything that's going on?" And he said to her, "The person who knows most about this disease is right nearby you. His name is Roscoe Brady. He's at NIH. And so I called Dr. Brady and I told him that my son was just diagnosed, and I said to him, "Do you have anything for me?" And he said to me, "Young lady, if you knew what I had, you would come running to my door," which is exactly what I did. I went there and we had a long talk, and I said to him, "Look, this is what I want to do is I'm going to get I'm not going to do my own practice anymore. I want to come and work for you voluntarily, no payment or anything, because I reasoned that if I could be on site and see what's going on and understand it, I would also I would be able to access as soon as possible for my son." And during the next 2 months, he became extremely ill. He was severely anemic, had massive splenomegaly and hepatomegaly, and had petechiae all over his body. And it was a very difficult time because we were really sort of in a race that we didn't realize we were in, because he was just on the edge of high output failure. And so December 21st, I think it was, of 1983, Dr. Brady called me up and said, "Look, we've finished with our preliminary experiments, and we're ready to infuse this in one person. Do you want your son to be that person?" And I said, "Absolutely, absolutely." And I think, of course, it helped me because it helped me being a physician, because I understood the chemistry, and I understood a lot more about the molecule that was going to be infused into my son. So I didn't have really worries about that. And actually, it was very interesting because when we had that first infusion, everyone in the greater hallway, let's say, all the different offices, everybody poured in to this room to watch this little boy get an IV infusion. And they had a crash cart. It was like something you would see on a TV show. And we just were there, and he had the infusion. And then Dr. Brady said to me, "Bring him back in 1 month." And all of a sudden, and I really want to convey this to all of you, I got like almost like a voice in my head, a deep knowing voice that said, "You have to insist that it's once a week." And for a microsecond, I questioned myself, but I just listened to that voice, and I said to Dr. Brady, "No, I should bring him back next week. It should be once a week." And he looked at me and he said, "With all due respect, what do you know? This is not really your field. How can you say that to me?" And I said, "I don't know how I can say it to you, but I am begging you to listen to me. You need to give it to him once a week." And he looked at me and he was totally silent, totally silent. And then he opened his eyes, because his eyes were closed, and he said, "You know what? Okay, I'll listen to you. I'll listen to you. We'll do it." And we brought him every week for 7 weeks. And in that 7 weeks, it was absolutely miraculous. No matter how many times I tell it, I relive that miraculousness, because all the petechiae disappeared, and all the other bruising, and his platelets obviously went up, and his anemia went from, I don't know, 4.8, 5.0 up to 8.5. It was incredible. And further, it was like someone took a pin in a balloon and just let the air out. His abdomen just shrank in front of our eyes. No, it was, I wish I could show you that picture in my mind. It was just absolutely incredible. And then they ran out for 7 weeks and he reversed. Everything went down again. It was just an unbelievable roller coaster ride. And then they got more because they were making it along with Henry Tremere, may he rest in peace. He, it was like this unbelievable synergy of events. And anyway, they made more of it. And bear in mind, this was a placental, it was coming from placenta. And of course, it had to be purified and then further modified with the mannose-6 phosphate modification, which became Ceredase. And then they resumed it, and the same thing exactly happened. Everything, everything got better, and even more so, like even more improvement. And we were just astonished, astonished. And then they ran out again, but this time, and we learned something from this, there was like a reservoir effect. And so he didn't get as sick as he had the first time. And then, of course, ensued the trials and so forth. Now, to try to explain uh, what it felt like to be told that your child was going to die very soon, because from her perspective, she had, and by the way, this was a fine institution, a fine hospital, but she had no idea what was going on at NIH. She had no idea. And so anyone that came her way with that condition would have been told the same thing. But thank God for my mother. Really, we've had a series of miracles about this. And the head of the Weitzman and Dr. Brady and Dr. Barringer and Dr. Barton and and of course, Henry Tremere. And then basically, what happened in my life was that I had a complete um, career trajectory change. And we realized that there was no real viable organization to help other people, because the thing is, I made this deal with God when he was so sick, and I would go every night by his bed and everybody else was asleep, and I would pray to God and say, please show me a path, show me a way of saving my child's life. And if I have this path and I can save his life, then I commit to helping all the other people, or as many people as I can, let's say, in the whole world, if I can, with this disorder, with this disease, to help them find this healing as well. And that's honestly, I've honored that commitment for the last 43 years, really, and we continue to do it. And I this is kind of it's not the end of the story, it's sort of the middle of the story of life. So ultimately, two more of my kids, I have 6 children, and two more of my kids were diagnosed with Gaucher's. And of course, they were the second one that was diagnosed was put on treatment when he was about 5 or 6. And this was still before it was approved, actually. But it was under a trial. And then the youngest one, actually, because there were no trials opened, he was given at the age of 2.5, I think it was 2.5, under compassionate, like a compassionate clause. And so all of my kids have been on ERT since then. And now, thank God, I have 26 grandchildren, and actually 17 of those grandchildren are from my adult sons. Thank God they're all well and married and successful in their work. Brian has 5 children, and my son Joshua, who lives in Israel, has 7 children, and my son Ben, who lives in Florida, has 5 children. And so it, it's really a it's really a true miracle. And I'll tell you that one of the hardest things for me, uh, we actually opened up a global diagnostic and treatment initiative. And the most difficult thing emotionally, honestly, for me, has been to realize how many people don't yet have access to treatment. It's so nerve-wracking in a way for me. But we're trying, and we are doing the best I think we can. And there's lots of people now who are working globally to try to reach more people and access more treatment and so forth. And so I I you heard the heart and the mind, the heart and the brain, the heart, the intellect and the emotions. Um, I'll tell you, as a physician, as a physician, because I have this remote practice now, and I see many, many different patients, and their parents or adult patients. As much as they need the ERT and the follow-up and the proper follow-up, they also need the physician's heart. They need to know that they are not alone, especially when they're at the beginning of a journey. So much of my time is not only giving people medical advice or in talking to their physicians who may know a little bit less about this disorder than I do. So much of my time is spent in in giving people hope and in giving people courage, and in also explaining to parents the fine line between your own feelings as a parent, your own concerns, your own wanting to shield your kids, and to sort of soften the bumps. And when you have a child that has a medical condition such as this, the immediate feeling is, I have to shield this kid even more. I have to I have to worry about him even more. So this is also part of the task of of allowing the child to be a child. Kids get hurt, they fall, they things happen. And that's true for all children. And so I think that as a physician, and I wish I could see all your faces. It's a little weird not to be able to see everybody, but um, when you're dealing with your patients and you're dealing with parents when you have little kids that you're treating, it's so important to put all that in put all that inside of you and put all that to your direct it and direct that energy of hope and courage and healing to the parents. And when the kids are a little bit older, when they're teens, um, allow them to express their teenageness freely, and not worry that something amiss is going to happen because they have this condition. And particularly, of course, when they're on adequate treatment, And so that's really what I wish to convey when I tell this story. It's not only, let's say, it's not only a story of inspiration, but not only that, but also sort of a prayer from me to you that you approach this with a sense of wholeness towards your patients. And I think that's really and a sense of love and caring and compassion and strength, because people do need strength to deal with these, various, many conditions, this being just one of them. But I really, from the bottom of my heart, I'm so grateful. I'm so grateful to be here in this Zoom land. and and um and I wish I could see all your faces. And maybe someday that will happen. But I really want to thank all of you so much for showing up and for being healers and caring about your patients and wanting to learn more, and so that it helps you grow as a person and as a physician and as a mother or a father, of your own children. And that way you can show up to be the best the best person that you can be. And I'm really thankful so much for having been invited. Thank you all very, very much. And that's it. I'm done.
Indeed, every word was full of emotion, of hope, and of perseverance. Really inspiring, an authentic story from a physician, from a mother. I'm sure this story is going to shed light onto our paths, onto our journeys, not only professionally, also in terms of human to human communication. We see how important perseverance is in the success of a treatment. And here, we are not talking about our own children, we're talking about all children, all diseases, all patients. Physicians have to keep that promise, and this is what we heard from Dr. Eli. So we would like to thank her for what she did for her son, for her sons, for all of us, all our patients. Thank you very much. This was really an inspiring story. Thank you. Dr. Robinelli is going to leave us now. We're not going to take questions for her, but we can take questions for the other speakers we have here. So you can ask your questions in the chat box. Thank you, Ellie. She's speaking English now. Yes, I think she is leaving. Okay, this is science. Here we have a hybrid meeting. We are not only together at 12 locations in Turkey, but we also are in contact with speakers, with experts in the US, and we can discuss science. The reason we can discuss this is that we have extensive experience in LSD in Turkey. We have many cases here. Now we're going to listen to another scientist from the United States. We have Dr. Wyneb, and he completed his training at the Mount Sinai School of Medicine in New York City. A very important person. Together with Brady, he started to work in 1977 on lysosomal disorders, and they worked on the definition of Gaucher and the formulation of the procedure. Right now, he's at the Miami University. He's working at the Cancer Center. He's also one of the founding physician advisors of the ICGG. So either he's touching human lives not only in medicine but also in other fields as well, and really a source of inspiration. It's going to be an honor to listen to him. The floor is yours.
Thank you very much, and it's really a pleasure to be here. Very difficult to follow my friend, Dr. Robinelli. and to duplicate the emotion and the strength that she did. What I was asked to do is to sort of combine a scientific presentation with some reflections of my own personal experiences with Gaucher disease as an investigator. And I think it's important to realize that when you work with a disease, as I have for uh, more than 50 years now, you develop a very clear emotional attachment, both intellectually as well as to the people that you meet. I actually had dinner probably, I think it must be 25 years ago or so, at Dr. Ellie's house when I was at a meeting in Washington near where she lives. And all the children that you heard about were still young at that time. But even so, it was so clear how much they had benefited from her efforts to get enzyme treatment going. So I only have 20 minutes, so I want to be cognizant of my time, but I want to just point out that as you're celebrating the 30 years, in the United States, we're up to 34 years now of celebrating either Ceredase or Cerezyme. It's fascinating how a drug which started over here in the United States in one location has now become a life-saving treatment in so many countries all over the world, many of whom have also made major contributions to our understanding of the disease, either through individual research, country-based research, or through international registries, and especially the International Collaborative Gaucher Registry, which I was privileged to be the chairperson of for almost 25 years. And it sort of was coincidental that Turkey turns out to be almost the center of the world in this particular picture. And I only recently learned how many patients you actually have with Gaucher disease, and the slide for most of that. But what I emphasized is that over the 30 to 35 years that this different countries of the world have had Ceredase and then Cerezyme available, it's amazing how much knowledge is spread out of just the one place in the United States, which is about here in Bethesda, to encompass so many different countries in the world. And if you look at this slide, I know it's probably just accidental, but with good reason, Turkey sort of looks like it's at the center of the world here with regards to Gaucher disease. And to some extent it is, because I only recently learned how many patients with Gaucher disease are present in Turkey. Somebody mentioned the figure of about 800, which would make it one of the largest, in terms of numbers, centers of the world, probably secondary only to the very large countries or countries like Israel, which happen to have so many Jewish patients with Gaucher disease. So what I want to do is sort of take a more scientific approach, but not leave the people out of it. So you already heard from Dr. Ellie about a very, very sick little boy who would have definitely died had he not been started on the treatment, probably within a few months of when he started treatment. But here's a lady who actually has the same genotype that Brian Berman has, and who lived with her Gaucher disease for 65 years before she became the treatment became available. And she did have the kindness to share with me her long-term story, which I think is typical for many patients who are very sick with Gaucher, but not as sick as Brian was when he was started on treatment. So she described when she was 10 years old, she began to have terrible pains in my legs. Again, bone pain is one of the very important features, particularly in adults with Gaucher disease, although, as you can see, it can start during childhood. And her mother had no idea what was causing the pains in those days. Everybody who had pains, their parents said, they're just growing pains, whatever that's supposed to mean. But as she continued to get older, her pains got worse, and then she started to develop problems with bleeding, as well as severe fatigue. And as she put it, I used to think I was the laziest person in the world because I felt so lethargic and tired. And she still recalled how she had had severe bleeding after the birth of her first child, and she was in the hospital for 17 days thereafter. And so most of her life was difficult. Unlike many patients at that era, she did not have a splenectomy done. She still had her spleen, which was very large. That accounted for a lot of her discomfort, as well as for the severe thrombocytopenia that she had when I first saw her. Her platelet count was approximately 20,000. So she was one of the early patients who started on what was then Ceredase in 1991, after the drug had been approved. And since that time, she also had an improvement. It wasn't quite as dramatic as Brian's in terms of speed. It actually took her almost 7 years for her platelet count to normalize. But fortunately, afterwards, as she got older, she developed other diseases, which is, again, a very important issue in patients with Gaucher disease. As they become older adults, they're not immune to many of the other diseases that we get as we get older, ranging anywhere from cardiac disease to cancer and all sorts of other things. And she did have several major surgeries. One was for renal artery stenosis, which caused her severe hypertension. And as she put it, had she not been treated for the Gaucher disease, it's very unlikely that she would have survived those surgeries or lived as long as she did. So she told us that she felt very fortunate to lead a normal life when she was 81 years old. She was still she was reading, busy, had a positive attitude. She had a very marvelous husband who unfortunately passed away of a cerebral hemorrhage shortly before she died. And Betty died in 2011. She was 88 years old, certainly a very good life expectancy, or one which isn't so surprising nowadays. And she did not die of anything related to Gaucher disease, but rather related to kidney failure and congestive heart failure. So in the video, you already saw the early period related to Gaucher disease, and I'm not going to reiterate except to mention that many, many investigators in an era when we think that medicine was very primitive, and we look back and say they didn't know anything. We need to be very humble about our own status and accomplishments today, because every one of these individuals made a major contribution to the disease process. Philippe Gaucher, Professor Brill, first described the disease as a genetic disorder, even though they didn't use the term then. It was called a family disorder. Professor Aguillon first described some of the neurological phenotypes, which are very important, particularly when I'm speaking to a Turkish audience. And then, of course, we come to I'll skip over Dr. Brady for a second, but because the disease is a lysosomal storage disease, one certainly has to give mention to the Nobel Prize winner, Professor Deduve, who actually first discovered the lysosomal organelle and then contributed to much of our understanding about it. Although, again, with modern science and studies, which he did not have available, we've learned so much more, but he was the pioneer in that regard. And then, as I say, I'm going to talk about Dr. Brady, since he was my mentor and the person who introduced me to Gaucher disease. But it occurred to me that for those of you who are involved with stuff like the World Cup, we always remember, or the Olympics, we always remember the winners, the person who gets the gold medal. And sometimes we forget the people who get the silver medal or even the bronze medal. And something like that actually really happened with Gaucher disease, because shortly after Dr. Brady started to published his information about the cause of Gaucher disease, another very great hematologist named Dr. Ernest Beutler, who became famous primarily for working with red cell disorders, got into the Gaucher arena. And even though everybody remembers that Dr. Brady was the one who actually led to enzyme replacement therapy, there was a race between these two great individuals in which Dr. Beutler came in second, because he was also working on developing enzyme therapy. And I think many people perhaps don't even remember that he actually infused several patients, but he was a little premature in that he had not yet been privy to the discovery of having to target the mannose receptor with modification of the enzyme, which is something that was discovered in Dr. Brady's laboratory. But I was a friend of Dr. Beutler's. He has an award at the American Society of Hematology named after him. He was a great hematologist who was deserving of winning a Nobel Prize in his own right. And nevertheless, he was a second place finisher. So what I'm going to do, though, is talk about my era, which is what I was asked to do. And I'm not going to go through this in too much detail, but I can't resist mentioning that my very first paper, when I worked with Dr. Brady, involved proving that Gaucher disease and some of the other sphingolipid storage diseases were due to enzymes which are localized in the lysosome. And I guess I'm very proud of that. That paper it was a long time ago, but it certainly has, I think, been a key element in investigations proceeding with Gaucher disease. The enzyme deficiency was described in 1965, and as soon as that happened, Dr. Brady was already thinking about replacing enzyme in patients who had the disease. I was assigned initially to also start working on purifying glucocerebrosidase. I was a very young, inexperienced investigator then. I didn't realize that it wasn't going to be a 2-year project. But I did actually contribute some of the initial steps in the purification. But after I left the NIH, Dr. Brady and Dr. Penchev continued, and in 1973, they had managed to actually make a purified glucocerebrosidase product, which they infused into 3 patients with very variable results. And again, they had no idea about what would be required to modify the enzyme to make it effective. And I think that was sort of frustrating to them. If you see on the slide here, though, this is one of perhaps the more weird contributions that I made to the project. Dr. Brady was concerned that when you ground up the spleens, which we were using at the time to purify the enzyme, with the heat might be actually denaturing the enzyme. So he wanted a less vigorous way of breaking up the spleen rather than a blender. So after talking about it, he thought maybe getting a meat grinder would be a good idea. So we needed a mechanical one, not an electric one. So I told him, well, my mother has a meat grinder, which was a very old type one with a handle, which used to grind up chopped meat and other stuff like that. So I called her and she donated her meat grinder to the NIH. And that was used actually as an important tool in purifying the enzyme. And I understand that meat grinder actually ended up in the museum at the NIH. Anyway, moving on, eventually, with a lot of hard work, and a number of different steps, which involved purification with affinity chromatography of what then was placental enzyme. And you can see Dr. Beutler did one of those studies. And then, of course, Dr. Brady with his partners, Dr. Furbish, Henry Blair, who later became a founder of Genzyme, Peter Penchev. They eventually designed a large-scale purification technique for glucocerebrosidase, which would be suitable for human administration. And then Dr. Barringer, working with Dr. Furbish, figured out that they needed to expose mannose residues on the enzyme for it to actually have uptake in the liver and the spleen and the bone marrow. And that, of course, led to the formation of Genzyme with Dr. Blair and Dr. and Henry Termeer, and eventually to the Signal paper in 1991, which related the results of a 12-patient trial of patients treated with IV enzyme replacement therapy administered every 2 weeks at that time. And as they say, the rest is sort of history. And so I was asked to say, how did I feel during this early period when you couldn't treat patients with a Gaucher? And as I've had many of the same emotions as a physician that Dr. Ellie had as a patient. She Became very friendly with some Gaucher patients. One in particular actually was as a medical student, came just as she wanted to do, came to work in Dr. Brady's laboratory. He was there for a summer internship. He eventually finished his residency, and I ran into him again at Mount Sinai Hospital when he was just completing his residency in psychiatry. And unfortunately, not long after that, he somehow developed a cervical fracture. He became quadriplegic and unfortunately passed away at a young age. And all of this happened long before we had enzyme available. And again, I think that had he been born later on in life, his life would have been very different, and who knows what he might have been able to contribute. And there were many other patients similar that I encountered for whom it was very frustrating to say, well, I know how to diagnose it. I even know how to do the enzyme assay to confirm your diagnosis, but I have nothing to do to help treat you. We learned that we should try where possible to avoid splenectomy. That was always a very controversial topic, but I think everybody has now agreed that splenectomy is unnecessary with enzyme replacement therapy, and that when it is done unnecessarily, it can lead to additional complications. So again, here is Brian. You saw him in the video. You have a better chance now to see that picture up close when he had this huge spleen. This was certainly before he got the treatment. Dr. Brady is the hand in the picture. I think if you pay close attention, you'll see how pale he was. And he was also dramatically growth challenged at the time, very sick. And as you heard, he was virtually dependent on enzyme in the very beginning just to sustain his hemoglobin at a livable level. Now, of course, most Gaucher patients at this age are not as sick as Brian is, especially if they have the Ashkenazi Jewish genotype, which is seen, of course, in Turkey as well, the so-called N409S homozygote or N370S homozygous. But there, I would want to just point out, I'm going to go over some of the accomplishments of the Gaucher registry very shortly. But a recent paper, which I didn't include here, was published by Dr. Pram Mistry and other members of the registry, emphasizing that we still run into individuals who very early in life are as sick as Brian is, and how important it is to make the diagnosis, to not delay, because there are still children who are dying of Gaucher disease because they are not properly diagnosed, or as Robin mentioned, sometimes the treatment is not available. Obviously, this doesn't happen as much in first world countries, but more so in countries where the medicine is still somewhat less developed. But it's a very important thing to emphasize, because everybody sort of thinks now that Gaucher disease is easily treatable and it's not really so bad to have, but there are still individuals who are not doing well very early in life and who may end up dying unnecessarily. And the picture here is a better picture of Dr. Brady, and this is Brian after he had therapy, but as you can see, when he was still a young man in this picture, a child basically, much different. You see no spleen here. He's active and vigorous. And we have pictures of him, which I didn't include, with his family, his wife and his children. So again, the emotions of being able to do this, I see I'm already past my 20 minutes, so I better move along. Okay, so what have we learned in over 34 years of treatment? So in 1991, the Gaucher Registry was created largely as part of the conditions of approval, and the goals were to contribute to medical and scientific understanding of Gaucher, to improve the quality of care for patients, and then to serve as a research base for further understanding the disease. The growth of the registry was very rapid in the early days. By 2012, there were almost 6,000 patients. Obviously, unfortunately, some of the older patients are no longer in it as they've passed away. So now the current enrollment of the registry is a little bit more than 7,000 patients with Gaucher disease from all over the world. And unfortunately, I would say there are still a number of countries with large numbers of patients, including France and China, who for regulatory reasons are not able to participate in the registry, but as country registries, they still contribute much information. So the registry has been able to become much more sophisticated with time, going on from what essentially are just descriptive studies and demographic studies, eventually to analyses of subgroups, such as a paper which was published looking at the effect of ERT on bone crises and bone pain. And then we got to the point where we could have enough patient material to actually look at dose response models and to really start to understand a lot more about giving enzyme therapy. So some of the accomplishments of the Gaucher registry over the years included a number of papers looking at Gaucher disease type 1 in children. Again, this becomes a very important area in countries where there are more aggressive genotypes than just the homozygous N370S genotype, and where disease does present very early on in life. The earliest publication had to do with growth retardation in children with Gaucher disease. And then there have been a number of definitive analyses about the response to enzyme replacement therapy, recommendations for monitoring pediatric patients, and again, specific looks at certain populations, such as in Latin America, where the phenotypes of the disease are considerably different. We've spent a lot of time in the registry looking at bone disease and its complications. One of our more recent publications in 2021 was a tool that was developed to try to assess the risk for fracture in patients who were starting treatment with imiglucerase for type 1 disease, along with other monitoring studies such as DEXA. We spent a lot of time looking at the issue about delayed therapy and how that can be disadvantageous. What are some of the risk factors for development of avascular necrosis, as well as fractures, and the effect of treatment on bone pain, which unfortunately is somewhat variable. When it started early enough in life, it oftentimes prevents bone pain from developing at all. Later in life, some patients have unfortunately suffered irreversible complications, and the treatment is less effective for fixing problems such as arthritis or collapsed bones or something like that, which is unavoidable because they were not treated early enough. There's been a lot of effort then concentrated on how to make effective diagnosis, how to follow patients in terms of are they achieving therapeutic goals, which is very important in terms of documentation, not only for scientific purposes, but to enable dose adjustments when they're necessary. Over years, we have found that in general, one is able to decrease the dose that patients are given once they have a good response to usually about half what the 60 unit per kilogram dose is. That's clearly important in terms of expense, if nothing else. And on the other hand, we also recognize that one has to be flexible about dosing. And just as Dr. Elliott mentioned, in the case of Brian, he was so sick that he needed to be treated every week. There are still individuals like that who the every 2-week treatment doesn't work. And they need to, even though, again, people are sort of somewhat reluctant to increase the dose, it needs to be done in some very sick patients. So without really carefully evaluating the response to therapy, those types of dose adjustments might not be made when necessary, and patients could suffer. It's also important to point out, I think, to every audience that I speak to, that not every event that we think represents therapeutic failure or progression of the disease on therapy is attributable to Gaucher disease itself. People do develop concurrent illnesses. So somebody who may have a bleeding ulcer and develops anemia and whose platelet count is normal, that presumably is not directly related to Gaucher disease. So the response there would not be to change the therapy, but to provide iron replacement, obviously, after stopping the bleeding. And there are other issues, including concurrent malignancies, myelodysplastic syndrome. So one has to be very critical in evaluating the response to treatment. The issue of neuronopathic disease is important. The registry has tried to have a specific neuronopathic disease registry. Clearly, the involvement of countries such as Turkey, Egypt, Japan, where neuronopathic disease, and those are just a few examples, where neuronopathic disease can sometimes represent 50% of the patients with Gaucher disease, and its various different subtypes also has to be recognized. So far, the results of enzyme replacement therapy for neuronopathic disease have been disappointing because of its inability to traverse the blood-brain barrier. Also, in the course of studying neuronopathic disease, a very important aspect to patients with Gaucher disease has been to try to understand the increased incidence of Parkinson's disease, Lewy body dementia, or Parkinsonism in older patients with type 1 Gaucher disease. And this continues to be an active area of research, as does the cancer risk, which seems to be largely confined to B-cell lymphomas, plasma cell disorders such as myeloma, and possibly to as the study, a recent publication just confirms, possibly to liver cancer, hepatoma, or hepatocellular carcinoma, and possibly renal cancer as well. So again, this is here. I just show you some. I'm not going to spend time because of lack of time on these cancer study. But this is, again, a fairly recent publication, which supplemented a previous study that we did in the registry back in 2005. We've also been able to, because of the consistent data that we've had in follow-up, been able to study the outcomes with Ceredase therapy to patients who on average have been treated consistently for 20 years or more. And basically, those study results confirm the efficacy of the treatment. It's been very effective for all of the hematologic and organ parameters, and it shows that growth develops normally in children. Fortunately, has obviated the performance of splenectomy in all except a very low number of patients. We were impressed, frankly, how good patient compliance is in taking a treatment which has to be given intravenously every 2 weeks. The advent of home infusion therapy or even self-treatment certainly has made that a lot easier. But the results, I think, confirm that Ceredase continues to be the gold standard treatment for patients with Gaucher disease. There are, of course, other enzymes, but the ability to study Ceredase over such a long period of time, I think, is an advantage that has conferred on it a certain amount of authenticity and, as I said, reliance as what perhaps might be best defined as the gold standard. So again, one of our goals is to hopefully serve as mentors for younger generations of physicians who will carry on with the newer types of research which are now available with innovative research techniques such as single cell transomics, three-dimensional culture systems, organoids, where actually we can perhaps start studying things like Gaucheromas in a culture system without having to use experimental animals. There seems to be basically no end to some of the modern developments. Of course, there's still the AI thing. If Dr. Elliott had even the internet at the time that her son was diagnosed, and today she undoubtedly would have done a search and would have found Dr. Brady and other people working in the disease without the heroic intervention of her mother. So we live in a new era now, and there are many, many new opportunities for this disease. I'm thrilled that I've been associated with it for such a long time. As you can see, I'm still active in it at age 81. It's Dr. Brady made it to age 93 when he fortunately passed away of prostate cancer, which was metastatic. But he actually worked in the laboratory and was publishing papers until he was 92 years of age. So I'm sort of hoping to follow in his footsteps and maybe even make it a little longer than he did. And I still hope to continue to be involved with Gaucher disease as long as I'm physically and mentally able. So thank you very much. I hope that everybody heard me. Okay, are we still there? I've been cut off.
Okay, it's a really perfect speech. Thank you very much. Her dakikasını yaşayarak
I
anlattığınız
enjoyed every
bu
minute of your
tedavinin
speech.
dünya
You talked about a wonderful
gerçekten
history of Gaucher
alanında
treatment
emeği
and
olduğu
its
için tabii ki de
history around the world.
fazla daha
And you
detaylı
have
bu konuyu
spent
bizimle
more effort in this
paylaştı.
area, more than anyone
Çok
else here.
teşekkür
And thank you
ediyorum.
very much for these
Tabii ki
wonderful
sonuna kadar devam edecek
comments.
sorular
We would be
kısmında
happy if you
Thank
could
you.
stay by the end of the
I will
meeting.
stay.
Thank you
I will
very much.
definitely stay around.
Dr.
I will
White.
be here if I can get the thing back on my screen. Here we go.
Hope to see you at the end of the meeting.
Right.
Bye bye.
Bye bye.
Evet, hepinize tekrar teşekkür ediyorum burada olduğunuz için. Çocuk beslenme ve
Thank you very
metabolik
much,
Dayanışması
all of you.
adına
Thank you very much
sorduk.
also to all the members of the Metabolic Diseases and Nutrition Association.
Toplantı yaptık. Bir spor
This is indeed an international meeting, a hybrid meeting. Today, we've listened to international experience now. Now we're coming to our own local experience. I will be talking about the journey in diagnosis. We have a professor, Professor Gülden from Istanbul University, the School of Medicine from Pediatric Metabolism and Nutrition. She will be talking about the journey of diagnosis and then the treatment, and then we will be talking about the exploration phase where we are contributing as Turkey. We have from Çukurova University Professor Derya who will talk about our publications. As you know, the Nobel Prizes have just been awarded, and one of them is Ömer Yashi, born into a family in Jordan. We're talking about tens of people sleeping together with the cattle. That's where his journey started, and it ended in Arizona at an Arizona University. And he thought, would I ever have a publication with hundreds of citations? I don't think we can even count the citations anymore. We talk about the improving, developing, and healing part. And he said when he was awarded Nobel Award, science is the most important power in the world that makes people equal. So this is how I would like to start. We have listened to the experts here. I'm not going to go into the details, but the journey started in 1882. There were 2 Nobel Awards. They had the definition of the enzyme, the gene. There were different experiments with treatments, but right now, we're still longing for a genetic treatment. We're still looking for treatments that would eliminate the disease. So right now, still our hands are up and open and we have question marks. This is a very apt title. It talks about the state of art and perspectives. And the author says, first, it's like a simple enzyme deficiency, then you have an accumulation of a substrate, then this is perceived as a biomarker, and then you have reactions. But then you see that it really becomes like art, and it's not only about lysosomes. It starts with the formation of the enzyme to the endoplasmic reticulum, from the endoplasmic reticulum to the mitochondria. you have oxidative phosphorylation, you have LIMP2, the adaptive protein 1, 2, the other carrying proteins, you have a chaperone like cytosine, and even more important than you have the alpha nucleates and the dairy particles. You have the relation to Parkinsonism. So we know now it's a very complex, complicated disease. So it's not a metabolic disease that has been demystified completely. So what are we talking about? We're talking about sphingolipidosis that is the most frequent globally. Right now, 1 out of 5,000 children in the world are born with LSD. Gaucher, Fabry, and Pompier are the most frequent, with an incidence of 1 over 40,000. These are frequently confused. We're talking about systemic inherited metabolic diseases. Usually, the diagnosis takes, on average, 7 years. Awareness is the key point here. It's important to have a family screening in countries such as ours. Newborn screenings, I have a question mark there. We don't know whether it would be appropriate in our country, but it's still important. There are still unknown parts in the physiopathology. For instance, where do we have a cardiac involvement, or why don't we have an effect on the cardiac involvement despite ERT? We have heterogeneous clinical and new involvements like hearing loss, and we still have unmet needs and cases with new involvements. Why do we discuss this topic in Turkey? Because we are the only and first country that has a discipline in metabolic diseases. Why? We have in our department both pediatric and adult patients. We have a high level of consanguinity. Turkstat says it's higher, but you will see in our registries that we have about 80% of consanguinity. We have a different distribution in subtypes. Our speaker from the state said we know that more than 40% is type 3. So maybe it's one of the cases, countries where we have the highest level of type 3. Not only the distribution is different, but you also have a difference in the number of patients, the distribution, the breakdown of different types from the east to the west of the country, from the north to the south. We're talking about a long treatment experience, as long as you would see globally, and we still have new cases and new findings, and we have national and international partnerships. We have 31 centers for metabolism diseases. 165 professionals work at these centers. Now we are in Adana. So if you have a line drawn from the north to the south, Adana is right in the middle. You see the differences of the east and the west together in Adana. So what about the symptoms of Gaucher's? Now we have more than 130 patients. So we thought, what could be the symptoms in each age group? We have many professionals watching us from different centers, so I think we can go into that. Now, intrauterine period, you have hydrophthalis and collodion. We have many publications from Turkey that contributed to this slide. I can say that proudly. And then for newborns, it's not only in CTX, but also in the others. Now in type 3 too, we can see newborn transient cholestasis. The journey continues. In early infancy, we have severe and acute neurological findings. This is especially true for Gaucher type 2. You have hypertonus here and bulbar involvement. Then you have infants and early childhood. Now you see visceral and hematological findings. You see hepatosplenomegaly, anemia, thrombocytopenia. and all three types of Gaucher. Then in children and in adults, you have skeletal involvements as well. You have osteoporosis, osteopenia. These can even start during your childhood. When you look at the breakdown, you see that there is no skeletal involvement, bone involvement in type 2. Then again, you see neurological findings, insidious findings. Neurological findings were only in type C, now type 3C. Right now, it's also among the findings in type 1, especially vertebral fractures and peripheric neuropathy are differentiating symptoms. The journey continues into adolescence and adulthood. Now, there you see some findings that cannot be eliminated despite the treatment. You have malignancies, you see Gaucheromas, lymphadenopathies, and neurological findings that you would see in type 3. So we see many different systems are involved in different age groups, and subtypes have differentiating symptoms. So this is the symptomatology for the different age groups. The stars show us that we're talking about a response. Visceral response is very good. In terms of bone response, some publications show us that there's partial response, but in preventing malignancies, we can say we're particularly effective. In addition to this, we have type 1 related, for instance, mutations in Israel, as have been reported, they can have asymptomatic manifestations. So how do we differentiate between the subgroups? You know that in Turkey, we have neurological involvements quite frequently. The subgroup that we see the most is the type 1 group. Type 1 is followed by type 2. It's less than 1%. In different ethnicities, we have 5 to 11% of type 3, and type 3C is again less than 1%. For the Ashkenazi ethnic group, type 1 is an important group. For the others, we can say they're pan-ethnic. Type 3 is more prevalent in Egypt and the Far East and East Asia. We have patients for type 3C that come from Osmaniye in Turkey. For hydrops fetalis, it's only type 2. We have a non-immune hydrops fetalis. So you see that a spleen, the liver, and the lungs are involved in all. Neurological involvement is also seen now in type 1. It's acute in type 2. It's subacute and chronic in type 3 and type 3C. Psychiatric findings can be seen in type 3C. Cardiac involvement only in type 3C. Gamopathies, malignancies, Gaucheromas. We still have type 1 in the literature, but we've had some type 3 cases. So they have the same sequencing. So we have a continuity in the spectrums, especially in the visceral and hematological findings. You see that when you have an early onset, with a close follow-up, they can turn into type 3s. So you also need a very close neurological follow-up. You have common findings. What do you have? Gastrointestinal hematological findings, hepatomegalia, splenomegalia, anemia, thrombocytopenias on the hematological findings, leukopenia, autoimmune diseases. These are common, shared by all three types. Skeletal system symptoms are seen on one side from arthritis, arthralgia, fractures are in the skeletal system. Most of the patients get a misdiagnosis. Type 2 is only true for septic necrosis. Neurological findings is opisthotonus. Bulbar findings are seen in type 2, but horizontal palsy, Our neurological findings we see here for cardiac involvement, you have aortic involvement, that's idiopathic mitral valve calcification, that's in type 3C. So these skeletal systems, neurological system, and cardiac system findings help us differentiate from one type to the other. Then we have rare findings and immunological findings. Both monoclonal and polyclonal gammopathies are seen here, and we know that they are related to malignancies. Gaucheroma is reported more and more frequently, especially in some disciplines. Treatments cannot be given regularly. Then you have longer intervals. Then you have a lower dose in the treatment. We know that these are all related to Gaucheroma. So even if the patients are being treated, it might be intracranial, but usually it's the bone, spleen, the liver, and the mediastinum, as well as the lungs, that are involved the most. Pulmonary ones can be seen in all three types, we know. From dermatological findings, hyperpigmentation is seen more and more in type 1. Among new findings, we have ocular findings. It's not only opacities or clouding, but we also see ocular neuritis. Hearing will be explained by Professor Darya. These are the recent findings. Hearing loss is again a surprise for all types. Psychiatric findings can be seen a lot in type 3 patients, and in the literature we see one hematuria and one nephrotic syndrome. So that's a rare involvement. Again, renal involvement is a rare one. It's a challenging patient and diagnosis journey. Our colleagues will know these journeys. So one type 1 pediatric patient and one type 3 adult patient. Now, this is a pediatric patient, 6.5 years old. 4 months old, we had abdominal distension, and a patient was pale and irritable and was diagnosed with infantile colitis. Then at the age of 3.5, the patient came with fatigue and nose bleeding, and they said it was iron deficiency and anemia. At the age of 4, you had hip pain and difficulty in gait. It was reactive septic rheumatoid arthritis. The patient was hospitalized. Puncture was performed. Maybe if they had known of a Gaucher cell, they would have checked it. So you had infectious disease specialists, the hematologist, the oncologist, all of these different disciplines saw the patient at the age of 6. Then it becomes more dramatic. The patient has knee pain, thrombocytopenia, anemia. Most of the time, people think of leukemia. They had bone marrow aspiration. They saw storage cells, and the patient was sent to us, referred to us. These are non-specific findings like delayed growth, low weight, fatigue, frequent infections, but there are also specific findings like hepatosplenomegaly, borderline anemia, borderline thrombocytopenia, and high ferritin. What are the non-specific ones? Non-specific findings, a chronic process and a systemic assessment were the steps of this journey. So patient had many invasive procedures. We're talking about a big adult now, a young man, and he can now play football comfortably outside. This is again another interesting case diagnosed later on. Now, at the age of 6, she's short. She's 22 years and 9 months now. At the age of 16, she had mood disorders. Or at the age of 17, they think of psychiatric conversion. Antipsychotics and antidepressants are prescribed. Then a year later, myoclonic seizures start. The EEG is impaired. Then at the age of 20, you have resistant seizures. A triple antiepileptic treatment starts. At the age of 22, the seizures require a cardiological consultation. Then an catheterization shows that the aortic valve calcifications resulted in the patient being referred to us. I think non-specific is delayed growth. Borderline splenomegaly couldn't be explained. Borderline thrombocytopenia was misinterpreted, maybe because there was no physical examination that was extensive enough. They said a seizure, okay, is a seizure, but oculomotor apraxia was missed. But then with the cardiac calcification, the patient was referred to us. Just neurometabolic disorders, you have related, unrelated organ involvement, so that you don't have only a single neurological finding. You have behavioral disorders, you have psychiatric issues, mood disorders, you have systemic involvements, anemia, thrombocytopenia. They are easily missed. You have again a chronic process, and a systemic assessment couldn't be performed. So 6 adult disciplines saw the patient, first pediatric disciplines and then 6 adult disciplines, and then after 16 years the patient has a Gaucher type 3C. It's very typical. When she came in, she had those thick eyeglasses, but nobody checked the size.
It's not just with us, it's like this everywhere. Hematological oncologists were involved in this assessment, and GI organomegaly, anemia, and thrombocytopenia seem to be the presenting symptoms. And these patients may mostly go to a hematologist, general pediatrician, primary care physician, maybe gastroenterologists, and they all identify organomegaly and hematological findings. About 20% of the hematologists identify or think of Gaucher when the patients have 3 of these symptoms. We have lack of awareness. We know the disease not so well. It has a very different phenotype, confusing phenotype. It can involve different symptoms. It can be silent. Those are the reasons that they say. And there's a 7-year delay or postponement of diagnosis in 1 out of every 6 patients. So our colleagues say we need a simple guideline to guide us. There are some hurdles in the diagnostic journey. Iliad and Odysseus are the sagas. So he goes to Troy and fights for 11 years. And he then tries to go back to Ithaca, his home country, for 11 years, but he dies on the way. And this is how they liken the Gaucher journey to the diagnostic odyssey. It involves multiple systems and different systems. There are different symptoms. We have lack of awareness and knowledge. Every department or specialty looks at their own specialty in silos, not in a holistic way. We don't have genetic diagnostic opportunities, and there's missing screening of families. And for pediatrics, people are thinking of lymphomas or MDS, leishmania, or that's an infectious reason that grows the spleen, other LDDs, and immune deficiency syndromes. For adults, it's confused with leukemia, lymphoma, HCC, infectious reasons, and autoimmune disorders. I just said it's not with us, it's with other countries around the world. Here's an example of a 30-year-old male. Goes to hospital, gets checked. People think of anemia, cytopenia, but the ferritin comes out very high, and they think of hemochromatosis, and they start hemochromatosis treatment for 10 years, after which the anemia and thrombocytopenia is halted. And when they say, let's check the patient a bit more, and thankfully it's not an invasive procedure, and they see the enzymes to be low, and they diagnose the patient with Gaucher after having received 10 years of treatment. This is another patient with immune thrombocytopenia diagnosis, 31-year-old female, met all the parameters, had a certain level of anemia, and they diagnosed her as such. 6 months later, they identify splenomegaly, and they say in immune thrombocytopenia, that's not a symptom. And they realized that hypergamma globulin and ferritin elevation was found even from the outset. And this patient was diagnosed at age 31 following bone marrow aspiration. Bone findings are also misguiding. 38-year-old patient has no pain in a mass in a tibia, 5 times 9 centimeters of the mass in 6 months, takes many radiological tests. They rule out in this patient, and they think that it's a bone tumor. So they take a biopsy, and they see no other lesions, and the biopsy comes out with Gaucher cells. Here's another case who has had very severe arm and leg pains, as in bone crisis, because we said how skeletal findings may start at childhood. Sedimentation is high, CRP is high, patient has anemia, splenomegaly, and a certain amount of thrombocytopenia. They take a sample from the lesion, and as they do so, they take cultures. They find both staph and strep, and they say this is osteomyelitis. They do bone screening. There's a similar lesion in humerus and tibia, and they give the patient long-term antibiotic treatment, but the pain relapses, in which case they question whether they have missed anything, and they do a lot of differential diagnosis, and for 2 years give the patient methotrexate, thinking this is a rheumatoid disease. The patient is said to benefit from it, probably because it relieves inflammation to a certain extent, but the child's complaints relapse. For a short while, the patient takes steroids and smart medicines, but then there's another biopsy. See how long the journey is, many biopsies, hospitalizations. This is a odyssey that starts at age 4, goes on for 5 years. Here's another case of cryptogenic splenomegaly, and the patients underwent splenectomy in the Spanish study, both child and adult patients, and there's a 3.6% idiopathic splenectomy due to sphingo necrosis, and 1 Gaucher for every 3 Newman picks in these patients. So when you cannot find the reason in these patients, this could be one of the reasons. We say it's confounded with some diseases, mostly with Niemann-Pick. How do we differentiate? Liver findings and lung findings are milder in Gaucher. Bone findings not expected in Niemann-Pick, but expected in Gaucher. Ocular findings are different. Horizontal gaze palsy in type 3. If Niemann-Pick A, then there is a cherry mark in the eye. We talked about hemochromatosis. It doesn't cause dyslipidemia or hypergammaglobulinemia. It also is confused with Niemann type C and gaze paralysis. There is confused because of neurological findings, and bone involvement causes bone involvement, and MPS involves all bones, whereas in Gaucher, it's the femur and vertebra which are involved. Supposing deficiency can be ruled out with some genetic studies. Malignancies are acute, not chronic processes like ours. Acid lipase deficiency causes HSM and cytopenia, whereas in Gaucher, splenomegaly is not in the forefront, but there's liver disorder. From 1965 to 2020, the publications were compiled, and there are many scoring systems, and they came up with the Delphi consensus. The early diagnosis is based on family history and a Jewish ancestor. For type 3, 3 times more massive splenomegaly and horizontal gaze palsy. For others, findings, many different confounding factors are in place. So genotype-phenotype correlation is very difficult to make except for some mutations, especially when it comes to bone involvement and neurologic involvement. We need more studies according to this consensus. So when you have a genetic workup, you also need to assess the bone health and have an osteoporosis screening, regardless of the age, neurological assessment, good ocular examination, cognitive and motor functions must be evaluated. And they say that in order to identify the factors which play a role in the complex phenotype of the patient, we need more proteomic, transcriptomic, and genomic analysis, and maybe AI in every subgroup. And there are 3 pieces of literature they mention. Data from us, and I hope I've not exceeded my time. And first, I'll take a look at the Adana 13th Metabolic Diseases Congress held in 2015. This is from our Professor Derya. Back then, we had 390 patients, 164 children, 77 adults, a total of 241 patients in follow-up. Same period, Çukurova University had 51 patients, all being followed up. Type 1 is 76%, no type 2s, and 24% of type 3s. And maybe in time, we had an elevated awareness. Where are we now? So back in 25, we had 51 patients with the typing on the screen. 48 of them had bone marrow aspiration, 10% had liver biopsies, all were diagnosed with enzyme levels, but there was a 53% genetic verification. In 2019, typing has changed. 5.5% type 2 is now added. And as you see, type 1 went to 52.2 from 76%, and type 3 went up dramatically. And in 2025, there have been all these patients, over 120 patients, 51% type 1, 6% type 2, and 42.5% type 3. 26% of the type 3 are type 3C. So we do 100% genotyping and 100% enzyme assays. It used to be 75 months from the onset of symptoms to diagnosis, and it's gone down to 37 months. Male to female ratio, similar. Adults to children, almost same. 18 refugees. 81% consanguinity, 61.6% family history is a dramatic situation. Okay, we talked about how the phenotypes are different and the subgroups are different. The patients have a long disease journey, but we have covered some distance as well. Let's now take a look at 2 pieces of literature with recommendations. One of them says, let's not just check enzymes. Also, let's take a look at lyso-Gb1 at the same dry blood sample. And in this way, we don't need to take a second sample, blood sample, it seems. About 4,500 patients with low enzymes were evaluated. About 20% of the 426 patients had high biomarkers, meaning there's a reduced need for second samples to be collected. So this is one recommendation. Another one is about having difficulty in the detection of the subtypes. Here, a neurofilament light chain has been studied both in CNS and serum. These are released from the axons. It's a biomarker, and in neuropathic types, it's increased 4 to 7 times. In type 3, up to 20%, it gives us information, and up to 100% in type 2. We have a thesis Both axial glial protein and neurofilaments have been studied, and we're expecting the results. So these were all patients on enzyme. Same with us.
bizlerden farklı bir şey denilmiş ki tip 3'te BAEP normal demiş. Bizim tüp
But they say in type 3, this is BAEP is normal. Not in our cases, the BAEP. The evoked potentials, BAEP, are normal, but we don't know how to what extent this is true. I'd like to thank not just to my girls, but to my son and all our children, and always thankful to the founder of the Turkish Republic, whose establishment will be celebrated soon on the 29th of October. Thank you very much for listening. Okay, I hope I didn't bore you. We talked at length about symptoms and subtypes and types. Now I'd like to give the floor to a doyen of the specialty, Professor Gökçay, to talk about the experience in Turkey. Dear colleagues, dear friends, and distinguished participants, here we are gathered again on the 30th anniversary of Ceredase, and it's a great pleasure to be with you and share our experience with you. Thank you. When we look at Gaucher disease, to me, Gaucher is a disease of the firsts, and it's a pioneer disease. And if you ask me why, due to a lysosomal enzyme deficiency, this disease develops, as Dr. Neslihan says, with multiple system findings, very heavily studied findings, and the etiology and pathogenesis of all LSDs were shed light on by the Gaucher disease. So that's why it's a disease of the firsts. Now, today, we assess the Gaucher disease according to its clinical spectrum. It can be not easy to make a neuronopathic or non-neuronopathic differentiation. Although we can differentiate genotypes or enzymes, these the types of information do not entirely illuminate us in terms of diagnosis or prognosis, and we need new studies, as the previous professor has explained. So yes, we know the types, and there are some specific findings, but there's also a clinical spectrum and the continuation of the spectrum. The studies in Turkey show, so does our experience, the heavy phenotype is seen more prominently. So type 3 is more dominant in Turkey. So I'm wondering whether the milder types are misdiagnosed or not diagnosed, especially in pediatric ages. Similarly, in patients of an older age with osteoporosis or other bone findings, are they Gaucher disease patients? Have they been diagnosed or not? Looking at the historical journey of the Gaucher disease, it's again a disease of the firsts and the pioneers. There are two scientists I'd like to name. One is Philip Gaucher, who identified and defined the disease, and also Dr. Roscoe Brady, who's dedicated over 3 decades of his work at NIH, developing the firsts in treatment and diagnosis, spearheading the treatment of other lysosomal diseases, who also visited us. And I had a chance to meet him at a congress. After their journey, treatment and diagnosis is now possible to make in Turkey. Treatment is also a first, the first ERT and a turning point in a sense. What was before that turning point? There was symptomatic treatment and bone marrow transplant. And BMT did not always give positive results. As for symptomatic treatments, there were splenectomies to save the day, transfusions, or orthopedic operations, which did not provide a solution. After long-term studies, a placental Ceredase enzyme, alglucerase, was developed and got its approval in 1991 and got used for the first time in our patient, which I will show you in 1993 in Turkey. And then imiglucerase came to Turkey in around 2007, but in 1994 it was accepted globally. So 34th year of the enzyme treatment, as Dr. Weinreb said, and the 30th year of Cerezyme treatment is being celebrated. The journey of Gaucher disease in Turkey is in parallel with enzyme treatment. If you write Gaucher disease Turkey, you would see 105 publications in literature. And when you look at the related ones, there are 92 publications. The first one made in 1992 about the heart valve involvement, a rare type 3C. This is followed by other publications, increasing number of publications over the years.
Here you will see 51 cases for the treatment. Here you will see cases, single cases, or smaller case groups. But we see that in recent years, we've also seen more studies. So publications, now half of the publications are now focusing on the treatment. This shows how critical the treatment is for this disease. Now, the patient that we first diagnosed and treated is a 16-month-old girl, a consanguineous family, the second child of the family, vaginal delivery, abdominal distension at the age of 1, and then a bone marrow aspiration at the 16th month, diagnosed with Gaucher. What is the medical history? You have a sister, older sister, with delayed growth, hepatosplenomegaly, progressive anemia, frequent transfusions, increased psychomotor delays, respiratory problems, despite all the symptoms and the treatment. When diagnosed with Gaucher, the sister was lost, unfortunately, at of 3.5 years. Here, this is the patient's picture. When we saw the patient, you see the gaze palsy, we see anemia, thrombocytopenia, hepatosplenomegaly, a bleeding tendency, nutrition and respiratory failure, and we see rapidly progressing clinical findings. Enzyme is low. We used to have L4083P. Now it's a new nomenclature. A homozygous patient, a very severe clinical progression. Now we wait for a year for the first ERT treatment, and then at the age of 32 months, we start with aglucerase. Back then, we didn't have social security institution, and we had received a confirmation for 60 units of a treatment. There was an Asian European meeting, a second one. Professor Mahmoud was there. Maybe he remembers this table. Then we shared this table in his publication. So we have the start of the therapy at month 32. I think this is not working, says the speaker. And then this is the 9th month of the treatment. Weight is stable. Back then, the child had not been growing anymore, but now we have 4 centimeters of increase in height. Spleen volume and liver volume significantly decreased. 12.4 was what reached in hemoglobin. Platelets went from 32,000 to 88,000. So this only happened in 9 months. As I said, a reduced liver, a reduced spleen, a very good response to the treatment. And then you might say, what happened? Well, then it was the times when we had economic challenges in Turkey. So unfortunately, the next treatment was not approved. The medication couldn't be imported, and we couldn't continue with the treatment of the patient after the 9th month. And we lost the patient with an infection and a very severe condition. These are the 2 pictures I use the most for a treated and non-treated patient. 32 months, left and right. On the right-hand side, we had a very early diagnosis because of this sibling. We could start with the treatment at the age of 2.5 months. So 2 patients, same diagnosis, same age. And the patient on the right had an elder sister with Gaucher, had received enzyme treatment, but there were multisystemic issues, and we had lost the elder sister, but the other sister, the young one, is now healthy and doing well. She had been diagnosed early, and we wanted to treat her already when she was a newborn because her enzymes were low, but ketoacidosis was not high yet. Acid phosphatase was still low. It was homozygous when we looked at the molecular diagnosis. So we had a correspondence and investigation. She was 2.5 months then. Then with the new regulation, we started with 30 units. We started in 2018. Developmental stages were normal. Neuromotor development was normal. There was a physiological anemia, and when she was 1 year and 3 months old, we went up to 40 units. We couldn't go up to 60 units, but we thought we could continue with more enzymes. She had 2 minor traumas at the age of 2.5 years. She had a hip fracture and a left arm fracture at the age of 3. She had a low bone mineral density, but for type 1, the standard dose was probably not enough for this patient. When you look at the RT dose and the relation to osteoporosis, we see that this actually is an issue, we might think, that starts at a later age, but no, we see that at earlier ages, this is also very significant in our patients. So what is important here in the diagnosis and treatment? Enzymatic diagnosis is important. The genetic counseling becomes important. We need to identify the phenotype. You need to have a treatment plan, but it has to be customized. We do not have newborn screening right now. They all come with symptoms, so they all deserve a treatment. So when you look at the enzyme levels, the mutation analysis with the support of the biomarkers today, you need to have a hematological assessment, a visceral assessment, an assessment of multiple systems. We have to look at the bones as well. Regardless of the age, we have to look at the skeletal symptoms if there are any. So a customized ERT dose has to be established for each patient individually. And then looking at the response, we need to modify the dose. Why? Because we see that with low ERT doses, we can continue to see Gaucher's complications. For instance, Gaucheromas are also phenomena in the bones that we observe in our patients. What do the guidelines say? They say for anemia-related symptoms, for the bleeding, for the visceral findings, for all of these, you need to have long-term and short-term targets. For most of them, you can bring down the symptoms to the desired levels, and we also have long-term targets here in the guidelines. Now here we have 20 years of experience for imiglucerase. That was in 2021. And as this is a slide that Weinreb mentioned, he couldn't talk about it, but the 2 to 5 years analysis and the 10-year analysis serves as a very good comparison. You see, in 20 years, patients that received imiglucerase treatment have a 20-year assessment of their hematological, visceral, and bone parameters. We see that in all these assessments, the disease was under control.
Bu registry'ye ilk kaydolan hastalar üzerinden 20. yıl çalışmasına kadar kalan
Now, here you see
hasta üzerinden
475 patients who have the start, the 10 years, and the 20 years of the treatment. When you look at the 20 years of treatment, we see that from the therapeutic targets, you have less bone pain, liver volume, spleen volume, hemoglobin platelets, and patients that have no bone crises. These are the criteria. These are actually the treatment targets for type 1, for type 3 patients. The criteria will be further developed. There are no criteria for type 2 right now. Now here you have one publication by a group of professionals at the Hacettepe University. You have 38 children, 16 years, a longitudinal study. We see that you have lower anemia, a lower liver and spleen volume. Growth is normalized, still lower than peers, but growth normalization takes longer than reported. And they say in our patient population, this is our case. So to summarize, in Gaucher type 1 patients, as of the first 2 years, you see an improvement in the quality of life with the treatment and a good response in hematological and visceral findings. With a long-term ERT, we see in terms of crisis and bone pain, in bone involvement, there is an improvement. There might be a problem in the enzyme reach for infarcts. Right now in type 2, there is no promising treatment yet. Maybe it's a cerebral apoptosis because there is no residual enzyme at all. That might be the explanation. So it's important to develop a treatment there. For type 3 patients, we can receive a response, although it's reported that we shouldn't expect an improvement in neurological findings, but still, although it's debatable, we see that ERT is beneficial for some patients. That's the impression, but new treatments would be critical here. In conclusion, what are our recommendations? Treatment recommendations have to be separate for phenotypes and genotypes. We have guidelines for type 1 right now. According to these protocols, with the treatment available, we have frequent, rarely reported clinical complications. So we have to apply for treatments that are not indicated, which means a delayed treatment and permanent damage. So in this period, customized treatment becomes more important. So we need to develop our own diagnostic and therapeutic criteria for our patients. Early diagnosis and treatment are important for the prognosis in Gaucher's disease. the indices, high-risk populations, newborn screenings are important. We need to have evidence-based scoring, which is important for our patients. Biomarkers should be developed here as well. I think I missed this slide. I'll come back to it. Now, ERT has been used for more than 30 years in our country with success. Contemporary literature contains many publications from our country. We have many publications for single-center patient groups. We know that information will be valuable if we have multi-center studies, so we need more information on our diseases. We are in October, the month of the International Gaucher Day, and Sanofi has supported this meeting, and I would like to thank them for this support, and I would like to thank you all for your attention. Thank you very much, Professor Gülden. She's been very apt in smoothly delivering the key points to us. Now we have a young scientist. Our speaker from the United States was looking forward to this presentation, the novelties and the new discoveries. Thank you, Professor. We are very happy to be here with my colleagues in front of you, the distinguished professors. I would like to thank my professors and the Sanofi team for the invitation. I would like to share with you some rare findings that I think might be of interest to you. As my professor said, this is the LSD that is seen the most frequent. We know the most about this LSD. And it's the first lysosomal storage disease that is treated, but still what we don't know about the disease is more than what we know about the disease. Yes, we have 30 years of treatment experience, and for our center it's 22 years. Still, despite this experience, every case teaches us something new. I would like to share with you the first case now. Now we have a consanguineous family. Nothing abnormal about the delivery. When the patient was 16 days old, came with ecchymosis in the neck and the knee, had direct bilirubinemia and HSM. And bilirubin was 14 point, AST was 200 and 400, ALT 100 to 200. Nothing that was abnormal about the blood count. Then we followed up with the patient. Intrauterine infections or sepsis were all investigated, but we couldn't find anything. And then cholestasis was relieved, regressed, and the patient was sent back home. Then the patient's family remembered that at the age of 4, the doctor had said that there were abnormal eye movements. They said that the examination was normal. Because it was normal, they didn't pay much attention. The patient came back to us at the age of 5, very typical symptoms, distended abdomen, massive SM, bone marrow aspiration showed foam cells, and the patient was referred to us. We did an enzyme analysis and diagnosed the patient with Gaucher type 1. Started with an ERT of 60 units per kilogram. Then in the follow-up, neurological findings became more apparent. From 8 to 10 years of age, you have ADHD. We had to start Concerta. There were problems of adaptation to schools. Oculomotor apraxia and strabismus were apparent in the physical examination. At the age of 11, we did a genetic analysis of the patient, and we had a homozygous D448H variant in the GBA gene. So that was a Gaucher type 3C. That's a single variant that determines it. So when we see this mutation, this means Gaucher type 3C. Then we had some cardiovascular findings becoming apparent as well. We got syncope and cyanosis. We did an echocardiogram that showed aortic and mitral valve calcification and aortic calcification. With a critical aortic stenosis, the council decided to replace the valves. The patient was put into a procedure. At the age of 13, you had right infarctocorneal clouding as well. Hydrocephalia was also identified, and a left hemiparesia was shown. We asked for another ocular examination. There was no issue actually that the patient reported, but we found cornea clouding. The calcification progressed to such an extent that you had a cardiac failure, and a catheterization was planned for stenting, but after the procedure, we lost the patient. So actually, what we want to say is that you're trying to look at the path from a telescope at a distance. So we need to look in order to see. Usually, this is what we see as physicians in our discipline, and we might miss some important findings. So, but I believe that we are all capable of seeing what we need to see. What do we see frequently? Visceral involvement. This is what we know. And if you don't have these findings, the diagnosis is delayed even more. Liver transaminase elevation, cholelithiasis is what we also see, and rarely we see fibrosis or cirrhosis in our patients.
The most important finding in this patient was the transient cholestasis of the newborn. In MPC, CTX, citrulline deficiency, and mitochondrial diseases, we had this transient transient cholestasis. But when we looked back at the medical record, we found out that the patient was admitted to NICU. The family forgot to tell us. And when we looked at other Gaucher patients, we saw that other type 3C findings were present, which was very surprising. And as shared with the professors from Ege Hospital, with cholestasis and fulminant liver failure, there was a successful liver transplant and ERT treatment, which was successful in another center. Hematologic findings are also popular. The reason why the patients are transfused, especially when there's anemia or thrombocytopenia, leukopenia to a lesser extent, and bleeding diathesis may probably not the first finding. Neurological involvement is present up to 50% in the patients of our region, so we need to be mindful of that. Let's not expect the patients to present with these symptoms. Let's find them in our examination proactively. They can be acute or subacute or chronic due to mortality in type 2 and horizontal supranuclear gaze paralysis is in type 3 the most prominent one. Communicated hydrocephaly is also an important finding, especially in our type 3C patients, and there is mention of it in literature. And neck dystonia without further physical findings. Psychiatric involvements may be missed by pediatricians, but we need to find them out to improve the quality of life. In type 3C, there's cardiovascular involvement, which is quite dramatic. There's one homozygous variant, pathognomonic finding both in aorta and mitral valve, starts with calcifications. Let me show you. In the picture to the left, you see a milder presentation. To the right, you see a more prominent calcification in white. And stenosis can increase, may cause constrictions, and may cause mortality. Pulmonary HT, myocardial involvement, pericardial involvement may also be found. Rarely, but present, is ocular involvement, intravitreal or periretinal white marks or corneal opacities. Why, especially in type C3, we don't know, but uveitis and strabismus have also been reported. 2 of our patients have glaucoma, but it could be coincidental. Now let's share another case. This is a 13-month-old girl, had organomegaly and thrombocytopenia. We made an enzyme analysis and genetics analysis, had diagnosed with Gaucher type 1, started ERT 60 UKG, and at age 5T, we found oculomotor apraxia and gaze palsy, and we find it as type 3. At age 7, the patient had respiratory distress, pleural effusion, thoracentesis, and mature histiocytic proliferation was found, and this regressed on its own. At age 8, the patient had a lot of solid focal lesions in the liver, hypoechoic lesions, mediastinal, axillary, and inguinal multiple LAPs. And so we thought Gaucheroma or malignancies, we need to differentiate. We had a biopsy and found that there was an infiltration of Gaucher cells. So we thought maybe it is underdosed, so we increased the patient's dose to 90 U per kg. Afterwards, in the long-term follow-up, the patient had mildly deteriorated neurological findings. Liver and spleen lesions and LAPs were completely regressed. Gaucheroma is when the Gaucher cells come together to look like mass, like a tumor, and they mimic malignancies. Mostly they come with lymphadenopathy or focal liver or spleen lesions or bone lesions. These are seen regardless of splenectomy or irrespective of splenectomy, mostly during treatment period, but we don't know why. It could be insufficient dosage. In our cases, we've seen this mostly in type 3, but maybe this could be a genotypical peculiarity. Immune and autoimmune problems are also seen more frequently in Gaucher patients. In literature, we see a lot of studies, including Dear Sevilla's study. Malignancies more frequent than in society. And the next patient is showing typical findings, HSM and swollen abdomen, cannot receive diagnosis until age 4, and has repetitive lower respiratory tract infection. At age 4, bicytopenia has also developed. Patient is developed with Gaucher disease. This is a patient from many years back, and pancytopenia threatened life, so they had to do splenectomy back then. And there was a severe neurodegenerative process. DTRs went up in physical. Epilepsy has developed. LAPs. And only at the age of 14, the patient received ERT. There was increased neuroregression, failure to walk, uses anti-epileptics now because of epilepsy, and we go up to 60 units per kg. And despite that, the patient had another infection, lower respiratory tract infection, was intubated, mechanically ventilated, was hooked to PEG, and the patient died at the age of 19. We can blame it on splenectomy or delayed treatment or the genotype. But there were many other Gaucher patients in the family of the same patient. There was a nephew of this patient who didn't have splenectomy but had an early treatment, yet had a similar neurodegenerative process. And other patients in the larger family received delayed treatments, delayed diagnosis, but they got married and worked in regular jobs. So it's not just one reason, there could be other modifying factors to this disease. Chronic neurodegenerative process of this patient showed lung involvement. There was also interstitial lung disease, pulmonary fibrosis, restrictive lung disease, and pulmonary hypertension can be seen, especially in severe phenotypes. Delayed treatment increases mortality. This is an adult female patient presented with hepatosplenomegaly, and it's said to be chronic liver disease. Liver biopsy has been made. Fibrosis, pre-cirrhosis were mentioned. And in the larger family, it was found that four other relatives had Gaucher disease, so bone marrow aspiration was made and the patient had foam cells. We diagnosed with type 1, started ERT at 60 U per kg. We have been following the patient for many years without problems. HSM was regressed, cytopenia went down, but at age 58, there was an audiovestibular assessment of the patient without any complaints. And why? Because we found that with ERT, patients had longer survival, and other LSDs such as Pompe and Fabry, there was hearing involvement, vestibular involvement in Fabry. So we thought maybe this could be the case in Gaucher. Neslihan, Deniz, and I screened literature but found very little studies. So we said, let's screen our patients, and this is for type 3 neurological involvement. We did this vestibular dysfunction tests in all our patients, regardless of the type. And we found that there was loss of hearing in high frequencies and vestibular dysfunction. This was a Gaucher type 1 patient and no other individuals with loss of hearing in the family. And you know how this patient had Gaucher relatives? One of them also had hearing loss. This is double homozygous mutation, by the way. So we turned this into a study, and we found that hearing has been studied more in audiovestibular involvements, but not as much as other findings. And in some cases, we found it to be acquired. In some cases, it was born. Not a complete hearing loss, but mild to moderate hearing loss. Low or high frequencies may be lost. Same in literature, same in our study. And the perception of speech in background noise was also reduced. So especially in traffic, they have difficulty understanding what the counterpart was saying. Even if you can hear, you don't understand what they're saying. So this means there is a central hearing problem found both in type 1 and type 3, both in literature and in our patients groups. So don't think that this is presbyacusia, which is an increasing hearing loss because the patients are elderly. But we had 13, 14, 17-year-old patients, type 1 or type 3 patients who had similar findings. Vestibular dysfunction was only studied in one study. There were a few type 3 patients, assessed in very few patients. And here, we didn't only find it in type 3, but also in type 1. So this is a contribution to the literature. There are other findings one needs to analyze in Gaucher. So we need to identify the questions together and find solutions together. I think we can do that. There are the ones we know, there are the things we have discovered and findings that we cannot even imagine, but I think we can overcome them through hard work. I hope, and I know, and I hope that I wish to celebrate the anniversary of our republic. Thank you, Derya, for this enlightening presentation. Now, we are on the floor, on the stage. Can we display the questions from the computer? Let's read the questions from there, or maybe comments even. Dr. Daria can read much better than I can because of her eyesight. Okay, the first question is to Dr. Neslihan. As a doctor, in this 30-year journey, which one was the most effective patient? I mean, the patient journey which impacted you the most? A few. One was explained by Daria, had cirrhosis, and after 10 years of treatment, the patient said, I'm reborn. The other one was about reactive arthritis and rheumatological diseases and leukemia. And the patient said, I miss playing football, and now I can play football and I can even grow in height. We have some dramatic in terms of negative stories as well. We used to need some specific hospitals. Two type 1 patients had an accident on the way to Ankara. The father died and the daughter was hospitalized for 2 months because of intracranial bleeding. But thankfully, they are both grown up now. They have completed university education. The girl has become a lawyer. The boy is also continuing his education. Second question is to Gülden. For 30 years, you have been touching the lives of children. What has been the most valuable gain of this journey? Scientific achievements or touching the lives of patients? Who asks the questions? Very professional questions. In the 30-year experience, I mean, I started working in metabolism back in 1991, which was the year that ERT for Gaucher was found, but came to Turkey only in 1993. After which time, until Ceredase arrived, we had alglucerase, and we had great access problems. We lost many patients. There was a very high mortality because there was a very frequent type 3 incidence. And with I think the development of ERTs has been the most important milestone. So that seems to be, for me, the most important thing. Early diagnosis also shortening the diagnostic journey, prolonging lives, because some very highly symptomatic patients arrive very late. Recently, we had a patient who presented at month 9, and the patient had pallor and abdominal distension at month 6, and hemoglobin was 4.8. So this was a severe case. We could have lost the child, and there was enzyme deficiency, and the molecular diagnosis was interestingly homozygous for a rare variant, and type 2 phenotype was, mentioned before. We would not have given treatment if we thought it was type 2, but there were no neurological findings. So we started treatment in that year, and still the patient has no neurological findings. But it seemed like homozygous for type 2. So, I mean, experience is very important. An enzyme result, a mutation result, to be combined with clinical experience, to be able to give the patient the chance for treatment. No treatment in type 2, why should I give the patient treatment? That's not how we should approach it. It's not a uniform disease, but cytopenia, liver, and spleen is not enough. You need to have a more detailed examination. Oculomotor apraxia can be missed unless examination is made very carefully. If you are considering type 3, especially in cases where the symptomatology is very early and severe, EEG, neuroimaging, electrophysiological workup must be part of your spectrum of diagnosis. So under the metabolism roof, you need to have a multidisciplinary approach and follow-up. Yes, multidisciplinary, that I also need to underline, and multiple system assessment. This is very important, and this is probably a type 3 case, by the way, taking ERT, has some gastrointestinal findings, so probably progressing to Gaucher Roma. It doesn't affect fertility, by the way, good news for girls and boys. I mean, they've grown into parents, and we have ERT experience in pregnancy, usually at 30 U per kg. We had some patients who didn't receive ERT in the first pregnancy, but did receive ERT in the second pregnancy with a better birth weight and postpartum complications. We also had a patient we diagnosed during pregnancy with a sibling who had Gaucher as well, but could not convince the patient to receive treatment. By the way, we cannot immediately look at the patient and say it's type 2 or 3. We had a HSM patient. We couldn't do genetic workup. Enzyme was low. Patient had cytopenia. We thought it was type 1 and started treatment. But we realized that there was gaze paralysis, and then we said it could be type 3, and we increased the dosage. And then the patient was hospitalized for an infection. And then we found what the family even missed. Opisthotonus position, just like it happens in reflux or iron deficiency. And then at month 14, we changed the diagnosis to type 2. In the meanwhile, we saw that enzyme treatment did not have any impact on type 2, and the continued phenotype continues. And with experience, you can catch these findings more easily. Other questions? There are a few more, actually. This question's to me. You're one of the new representatives of the field. How do you think the future practice will be shaped based on 30 years of experience? Well, we rely on our professor's experience looking forward. Biomarkers have become more important. Genetic tests have accelerated. So those or maybe some biomarkers which can, for example, neurological biomarkers which would help us diagnose, or there are some cases which we cannot treat, such as the findings of the central system or cardiac system, and maybe these can be treated with new lines of treatment.
Perhaps substrate reduction and enzyme replacement therapies could be combined, because that will help with the bone involvement. Maybe the young colleagues here could work on gene treatment, maybe find something new, we don't know. Okay, there's a question to Dr. Weinreb. I'll read it in Turkish and it will be interpreted. Dr. Weinreb, now 30 years ago, it was difficult to even imagine the point we have reached today in the management of Gaucher disease. What do you think was the biggest turning point, and where did science experience its breakthrough moment?
Okay, do you hear me okay? Because I'm not muted anymore, I don't think. Okay, you hear me, right?
We hear you.
Oh, okay, good. Well, I think clearly the breakthrough moment was the development of enzyme therapy. It's changed the entire course and trajectory and prognosis in the disease. And it's, at least in a very large number of type 1 patients, it's probably extended their survival significantly and has made a huge difference. I think it actually has contributed as well, even in the type 3 patients, especially the not so much the type 3C patients, although I understand from some of the patients they have in Egypt that some of them, when they've had cardiac transplants, if they've been able to, have actually done very well if they continue on enzyme treatment after that. So and even gene therapy, at least as it's currently being studied, now that the ex vivo treatment has sort of been dropped, but the delivery through AAV viruses to the liver is essentially just an improved and augmented type of enzyme replacement therapy. Endogenous, it's true, but it's really based on pouring out large amounts of enzyme into the patient on a continuous basis. The question there is it going to prevent, for example, the Parkinson's disease that develops late on in patients with type 1 disease, because it still isn't really addressing the problem of a misfolded enzyme, which may itself bring its own pathology associated with it, through and that mechanism is probably not being addressed by that. So we still need to study that, I think, much more extensively. But bottom line answer, as I said, the enzyme therapy has been clearly a major breakthrough, and it also opened up the possibility of similar type of treatment to other lysosomal storage diseases with admittedly variable results, and not some as good as with the Gaucher disease, but still enough to make a difference for those patients. So that's what I would say at this point.
Thank you for your reply.
There is a thank you note for all. Professor Işıl says thank you to everyone. A note to myself. I understand that actually even early diagnosis in newborns is late. In my opinion, early diagnosis should be parental screening. Effective treatment should be pre-implantation genetics. If any research has been done on this topic, it would be great to share it. They say colleagues from other centers are thanking us. Anyone in the room with a question? Sorry, you're like stepchildren. We let everyone else ask, but what about you? Do you have any questions here? No, okay. I also would like to thank the speakers here. I would like to thank our speakers here from Turkey, our international speakers, indeed experts who have dedicated their lives to this field. I would like to thank all of our participants here, both physically and around Turkey. This is a journey where we change the lives of our patients. We would like to thank Sanofi, who is the architect of the drug that changed the lives of these people. Thank you very much and hope to see you in other meetings.